So welcome everybody to this session. I'm absolutely delighted and honored to be moderating. We have 5 really wonderful speakers, 4 of whom are actually with us as well. So I'm really looking forward to not just the presentations, but a very active and engaging question and answers. Before we get started, just a few housekeeping. First of all, we will be watching all of these pre-recorded, and then I will introduce individuals, and then we will have a lot of time, which is very exciting for questions and answers. I have already invited you to please put your questions and your answers, your questions into the Q&A, and we will be collecting them and then talking about them after the session, after the presentations. And if you have a specific speaker that you'd like to direct your question to, please do note that. So this is the panel on innovations in health management, planning, and regulation. And really an incredible, innovative series of interventions and results that are focusing on an area that's not often looked at, which is really looking at management and quality and other ways of how we actually can improve quality. So the first speaker is Munira Rashid. Munira Rashid is a psychologist by training and faculty at Aga Khan University in Pakistan. Over a decade of experience of implementing large-scale projects to improve human experience, ranging from mother-child interactions through lady health workers in a rural district in Sindh, to enhance leadership experience in subsequently leading to employee and patient experience outcomes in a private sector hospital in Karachi. She has also represented Pakistan at different international organizations, including UNICEF, World Bank, and World Health Organization. And I'm very excited now to watch her presentation.
Hi everybody, I am Munira Rashid from Aga Khan University Hospital, Karachi, Pakistan, and direct patient experience of care previously with the department. Today, I'm going to talk about evaluation of leadership mentorship as an intervention strategy that we carried out to engage the workforce for improved patient experience outcomes, a case study from Pakistan. So briefly talking about the background, patient experience is now greatly being recognized by healthcare leaders all around the world as an important strategy. It's part of their services because it's associated with greater patient safety and also quality of care. And employee engagement shaped by leadership has been found as one of the most effective strategies for improved patient experience outcomes. But there are certain challenges in low and middle income countries like Pakistan that makes it difficult to implement patient experience strategies, some of those being weak governance structures, or which it's a very physician-centric kind of model in the healthcare system because the physicians are rare commodities. There are few physicians when you compare physician to population ratio. And another challenge that we feel is there is a lack of focus during their trainings on how to create or how to develop them as leaders when they enter into healthcare. Just having a degree in medicine may not be enough for them to be leaders. So we thought of mentoring healthcare leaders around principles of sustainable transformation could be one of the strategies to bring about a culture change, and that could be worth exploring. Hence, the purpose of the study was to evaluate the effectiveness of leadership mentorship to improve patient experience through workforce engagement in a tertiary care children's hospital in Pakistan. The methods included creating a working group, which consisted of service leaders, business managers, nurse manager, people who are involved in the service, but also including a behavior and implementation scientist, someone who could understand what experience is and help to operationalize in an already working system, and also taking on board a leadership consultant. The intervention was designed using a theory of change model, and it was informed by a pain point survey with the employees, and it was just one of them. Like, what are the 3 main pain points that affect the way that you deliver your service to your patients? And from that survey, we included 3 tiers of intervention. One was to have purpose-driven leadership skills training for those, especially in a leadership role or a supervisory role, which included the service leader as well. So the idea was how to build a vision, how to communicate a vision, and how to have a larger purpose looking beyond your finances and volumes. That also resulted in having a social media communication strategy to connect the employees with the leaders, but also to shape new values and to shape a new culture of patient experience, and also something that values compassion as part of the experience. The survey also made us realize that there was a need of an on-job mentorship program for your staff, especially your nursing staff who are the frontline workers for your patients and who expect the nurses to be compassionate. But to cater to their needs, to cater the needs of our own nurses, we needed to have a systemic approach. And we recognize that the supervisor is the mentor or is the sister for a nurse. So the mentorship program included three layers as well, which included how do you be a good supervisor, have a visionary supervisor, how do you also invest into the growth of your own nurses or mentorship, but also how do you help them connect with the larger environment. We formulated a key driver diagram, and as you can see, the primary drivers included both a top-down and a bottom-up approach. The top-down approach included the service line leadership, valuing the patient feedback that we received, but also meeting basic humanistic needs, being respectful communication on an informal level, effective communication of the illness by the healthcare staff to the patient, but also meeting the emotional needs of the patient and the listening skills, improving the skills of the staff. And the main intervention included streamlining patient experience as part of the quality framework. How do you measure, how do you look after these feedback forms, and then training your service providers as well. The outcomes included were a quality improvement project led by the staff who was engaged, and this could be around either employee pain point or patient pain point, but eventually leading to patient experience outcomes. We also measured patient experience outcome using an internationally available tool called Health Consumer Assessment of Health Providers and Systems, and the number of themes of patient feedback forms received were also included. The results indicated that on nursing communication, there was a significant change from the baseline to the end line. And the nurses and the patients felt that the nurses started explaining things always in a way that they could understand. And also they felt they were being treated with courtesy and respect. And the number of patients who rated always went up from about 70% to mid 80%, between 80 to 85%, which was quite significant. We did not see any change with respect to change in physician communication. And we feel that it was around because we were not able to change anything for the doctors themselves or the physicians. Because that required a much more institutional level intervention. We also found change at the way the patients rated the hospital environment, and they felt it was much more quieter now. Many more patients also rated the hospital gave hospital as maximum rating, and much more also would like to recommend the hospital for their friends and families for admission. In terms of QI projects, some of the most effective QI projects were there were multiple projects, but some of them included play-based psychosocial service, which to reduce stress in children. Interestingly, it was a children's hospital where play was never used before, a kind of a service to reduce stress in children, especially when they're in pain, and to distract them. That was one of the most effective and most appreciated project by the patients themselves. We also introduced a well-coordinated communication strategy for physician handoff, and there was a change of physicians between the patients. We streamlined the admission process to reduce anxiety for the patients when they come in and they're not familiar with the system. So there was a system around that as well. And 2 other programs, which interestingly, one was around the trainee physician, and how did we improve their research skills so that that helps them to clear their exams, but also helps them to be better service providers in the future, to think of research as part of the service. And we also reorganized undergrad rotation in pediatric service and how it could be much more compassionate, how we do take care of the experience of our students. We concluded that healthcare leaders in LMIC can be effectively mentored for cultural transformation to engage workforce for improved patient experience outcomes. And the key recommendations are that there can be resistance when you start off, especially with the people who have been enjoying power for long, and in the face of change, there can be resistance, and leaders need to be mentored in strategic transformation with a clear purpose so that they can face this resistance, they can be prepared for it. But we also feel leadership experience should be included as part of healthcare training for these physicians who aspire to be leaders in their own settings or in their own context. Thank you very much.
Great. So thank you so much for a really wonderful presentation and really bringing up some areas that in traditional quality, we don't always think about, issues around leadership, as well as the importance of the quality experiential, not just the technical quality. I'm now moving on to Dorcas Kinwanuka Henriksen, who is not able to be with us today, but has a really great video for us to watch. Dorcas is the Senior Policy Advisor for Health and SRHR at the Swedish International Development Cooperation Agency. She has studied the health system with a focus on the subnational level in low and middle income countries, and looking forward very much to hearing what she has to share with us today.
Hello and greetings from Stockholm. I would like to share findings from a study that tested a management approach that relied on a customized set of diagnostic tools to identify and resolve health system bottlenecks and facilitate community empowerment at the district level. Countries in sub-Saharan Africa, including Uganda, are plagued with persistently high rates of child mortality. Previous studies have identified 4 factors that constrain performance to improve child health: a lack of supportive policies, an inability to prioritize high-impact evidence-based interventions, weak or broken supply chain for curative and preventive commodities, and the absence of community-based health promotion and care. Compounding the complex mix of challenges is the trend towards decentralization. Limited managerial capacity hinders the planning and management of decentralized health services, and communities lack the means to demand or demonstrate accountability for even the most basic health services. This study investigated how a district management strategy informed by local data and community dialogue influences health services. A 3-year randomized controlled trial was conducted in 16 high mortality districts in Uganda. To our knowledge, this was the first RCT of an intervention designed to enhance the district health management of select child health interventions. Prior to randomization, districts were matched based on an index of 20 child health epidemiology reference group child survival indicators. For each district, a composite index was calculated by summing all 20 child survival indicators and assigning a weight based on 3 components: level of coverage in the district, impact on child mortality, and the proportion of total mortality attributed to a specific cause. Districts in the sample frame were stratified or matched based on supplemental criteria, including geographical location, the date of the district's official incorporation, and the district level quality improvement intervention. After applying the eligibility criteria, the authors randomly selected 8 pairs from the remaining districts. A coin toss determined which of the 2 districts from each pair would be targeted by the code's intervention. As mentioned earlier, a set of customized diagnostic tools were used in the study to identify health system bottlenecks, to conduct a causal analysis and a management analysis. Using a difference in differences approach, an intention to treat analysis of protective, preventive, and curative practices for malaria, pneumonia, and diarrhea among children aged 5 and younger was conducted. The intention to treat analysis showed significant net increases in the effective coverage of treatment for symptoms of malaria, pneumonia, and diarrhea, as well as proper stool disposal. Coverage rates for immunization and vitamin A consumption saw similar improvements. Findings showed that for evidence to inform an action and prompt results, district managers must have the requisite physical space and authority to implement the corrective measures identified. The CODES trial is the first of its kind to test whether district-level management interventions impact child health outcomes at the population level. Implementation of the CODES intervention led to modest increases in the effective coverage of curative care for malaria, pneumonia, and diarrhea symptoms in population-based surveys. The findings indicate the model suitability for health system strengthening in Uganda and other decentralized contexts, and should be considered in efforts to scale up child health interventions across Uganda and in similar settings. Findings from the study also point to the need for balance between demand and supply side interventions, ensuring sufficient physical space and authority to local managers to act on findings, and the utility of implementation research to improve health system management. Thank you.
Thank you so much. Really very interesting and very important work, looking not just at the national, but the subnational, and focusing on management is really one of the key levers which can be pulled to be able to improve quality. I'm now absolutely delighted to move on to Jessica King. Jessica King is a research fellow in health economics and impact evaluation at the London School of Hygiene and Tropical Medicine. She uses statistical, epidemiological, and econometric methods to study health systems with a particular focus on quality of and access to care in low and middle income countries. Jessica, we could watch the presentation now. Thank you.
Hello, today I'm going to talk about management in health facilities and its relationship with quality of care and the evidence we found in Tanzania's private health facilities. This is a piece of work in collaboration with the Ifakara Health Institute, Farm Access Foundation and International Growth Centre, and was part of a wider evaluation of a quality improvement programme in Tanzania by Farm Access. So why quality of care? Well, it's an important item on the global health agenda, sometimes neglected when thinking about universal health coverage, but completely key. Without quality, access to care is irrelevant. There are several million deaths a year that we think are caused by poor quality care in low and middle income countries. It's a particular concern in private health facilities, which provide a significant and growing share of healthcare in LMICs and need to be included in the move towards UHC. But there are concerns about quality and safety because of weak regulation. Things like accreditation are only available to the higher level health facilities, not to those smaller, more frequently used ones. And there's really limited evidence on what's effective to improve quality of care. Management is something that we don't necessarily always talk about when looking at quality improvement. Most interventions are actually clinical level, looking at health workers, not the whole facility. In high-income countries and in the business world, there's a well-established relationship between management and productivity. But we don't know if this relationship is likely to hold when looking at healthcare in small health facilities in a country like Tanzania. For example, those formal management practices might not necessarily be useful in small organizations with few employees. Human resource constraints might mean that management actually could divert from providing good quality care. And if regulation's weak, management might instead encourage stinting on quality rather than good quality. So we wanted to investigate this question. And to do that, we looked at these 228 health facilities across Tanzania. Half of them were for-profit and half of them were not-for-profit health facilities, or in the private sector, mostly dispensaries, some health centres and hospitals. And in those health facilities, we measured 3 types of data that I'll talk about today. The first was management, measured by an interview with the facility manager in charge. We asked about 13 management practices, and then we verified those through direct observation. So for example, we asked if they kept patient records and then asked to see where the patient records were kept. To measure the quality of care, we observed the compliance with IPC, infection control practices, in the lab, the consultation room and injection dressing room in these facilities. And another measure of clinical quality of care was with standardized patients, that's mystery shoppers for health facilities. 4 of these standardized patients went to each health facility with the cases of a non-malarial febrile illness, TB, upper respiratory tract infection and asthma. And we measured whether those patients were correctly treated when they visited. So these are the domains that the management survey covered. An example here given is a training plan. And so the maximum score for each question was 1. And if the facility said that they had a long-term training plan, they scored 1. If they had something in between the maximum score and the minimum score, like a short-term plan, they scored 0.5. But if they didn't have a training plan, they scored 0. So a quick summary of the results of that management tool. The mean overall score was 38% of the maximum score. This varied a lot across the indicators. We can see that reporting to the monthly health information system was very high, 96%, but indicators like having a report of patient indicators, only 11% of, the mean was only 11% across facilities. And the range of scores aggregated across facilities was 0 to 92%. The relationship between management and quality was interesting to observe. So this is using a multiple regression where we controlled for other facility characteristics, and we found that a 10 percentage point increase in the management score was associated with a 2.9 percentage point increase in the correct treatment of standardized patients. And we can see that's significant at the 0.01 level. We also found that there was a significant relationship between compliance with the IPC practices, but that was a much smaller relationship. And as shown here, 10 percentage point increase in management score would only increase IPC compliance by 0.6 percentage points. Management also decreased antibiotic prescription, although that was at the 0.1% level of significance, and there was no relationship with unnecessary or harmful care. So what this tells us, there's a lot of scope for improvement in clinical quality of care. Overall, we found that there was 50% compliance with IPC norms and only 20% of our standardized patients were correctly treated. And we also found this relationship between modern management practices we measured and the higher clinical quality of care, even after we adjusted for facility characteristics like the level of facility and number of clinicians. We saw a really strong positive relationship between management and the correct treatment of our standardized patients, and a weaker but still positive relationship between management and the compliance with the infection control practices. And we also found that good management didn't increase the amount of unnecessary care. So the findings suggest there were improvements in efficiency as well. So this suggests that we need more policy attention on management. Most interventions are at a clinical level, often disease-specific or vertical. There are interventions like Tanzania's National Star Rating System and PharmAccess's Safe Care program, which are assessments that focus on these organizational level practices. And the evidence from this study suggests that that approach is a feasible way to increase quality of care. One thing to note is that we can't say that this relationship is causal. This was a cross-sectional survey, but we did adjust for facility characteristics, and our standardized patients do address the concerns that you might have about different patients visiting different facilities, because we always send the same patients. We'd also be interested to do further research to see if this relationship between good quality and good management would be the same in public sector health facilities. Another thing to note is that while the effect size is modest, we'd need a 10% increase in management score to increase our quality of care for patients by 3%. That magnitude is similar to other studies that have compared, for example, qualified and unqualified doctors in India. So this is just to thank our funders, and thank you for listening. Goodbye.
Great. Thank you so much, Dr. King. This is really, again, this, I think, very innovative in the sense of looking not just at the sort of the more targeted tests of change that we traditionally see with quality improvement, but what are some of the broader approaches. And so I'm now absolutely delighted to ask Catherine Goodman to follow up. Catherine Goodman is professor in health economics and policy at the London School of Hygiene and Tropical Medicine. She has over 20 years experience in applied health systems research in low and middle income countries, and her work particularly focuses on understanding and improving private sector healthcare provision. And this will be further talk on the same project. And so looking forward to continuing to learn more and ongoing. And again, just encouraging the audience to please put in any questions into the Q&A. Thank you so much. And Professor Goodman.
So hello, everyone. I'm going to talk about our evaluation, which focused on the quality of care in private healthcare facilities. In terms of private facilities, I'm thinking of both faith-based facilities and for-profit facilities, which have really grown in number in recent years. And there's concern about the lack of effective systems to ensure quality in these types of outlets. So we know regulation often has a lot of problems, and international accreditation systems are often only in reach of the highest end facilities. So the NGO Farm Access developed the Safe Care model to adapt international accreditation standards to low resource contexts. And the aim is that facilities should be able to make stepwise progress up a series of safe care levels. So the safe care theory of change is based on the assumption that safe care will improve the safe care assessment score, which is mainly measures of structural quality. This will lead to better clinical quality of care, and patients will then receive this high quality of care, perceive the improvements, increase utilization. This should improve business performance, and as a result, facilities will have more resources to invest into future quality improvement. Safe Care then intervenes at 2 points to stimulate this cycle. Firstly, by providing quality improvement support, and secondly, by providing business support. So this is the first RCT to assess the impact of Safe Care on clinical quality of care. 237 facilities were randomized to either the intervention or control arms, stratified by whether they were for-profit or faith-based, by facility level, and by region. The intervention facilities received a baseline and endline safe care assessment, a quality improvement plan tailored to their facility, training sessions, quarterly mentoring visits, and the opportunity to apply for a loan under the Medical Credit Fund. On the other hand, the control facilities just received a baseline and endline safe care assessment and a simple report on the assessment outcome. So I'm going to focus today on our results on quality of care. We draw for this on the safe care assessments at baseline and endline, and also the research team's own assessments of clinical quality of care, which were collected at endline. These were firstly observations of infection prevention and control practices, and secondly, the use of undercover standardized patients. For the IPC observations, our field workers sat in consultation rooms, labs, dressing and injection rooms, observing all the actions of healthcare workers and noting any which required an IPC action within these 5 domains. So for example, before or after touching a patient, the health worker should undertake hand hygiene by washing their hands with soap or using an alcohol rub and drying their hands appropriately. For the standardized patients, our field workers were trained to act as though they were real patients, presenting a standardized set of symptoms. And we had these 4 cases: asthma, non-malarial febrile illness, TB, and an upper respiratory tract infection. For each case, we defined correct management as shown here. So for example, for a reported history of asthma symptoms, they should have received an appropriate inhaler. Turning to our results, the Safe Care assessment scores are shown here for the intervention arm in blue and for the control arm in orange. So between baseline and endline, the average score increased by around 13 percentage points for the intervention group and 9 percentage points for the control, giving a significant difference at endline of 4.4 percentage points. However, at endline, we found no significant difference between intervention and control in the IPC results. Now, this result holds within the individual IPC domains and also for all domains combined, shown at the top of the figure. So you can see there that overall compliance was only just over half for all required actions in both arms. Similarly, for the standardized patients, we found no significant difference between intervention and control at endline, both within each individual case or for all cases pooled. So you can see that correct management was under 30% across all cases for both arms. So to explore the reasons for the lack of impact on clinical quality, we considered three things: the fidelity of implementation, potential contextual factors, and also the functioning of the expected causal mechanisms. So first, starting with implementation intensity, we can see that this was actually quite a bit lower than expected. So for instance, only 3.1 out of 5 planned mentoring visits took place. But perhaps this isn't so out of line for a typical operational setting. In terms of contextual factors, I'll highlight two things in particular. One was that there was a perceived economic downturn in Tanzania at this time, which certainly could have discouraged investment in quality improvement. And secondly, both intervention and control facilities were exposed to a range of other quality initiatives at the same time. And it's possible that as both arms were experiencing these other initiatives, this could have dampened the measured impact of safe care in our results. And we particularly highlight here the government's own star rating assessments of facilities that used a similar tool to the safe care assessment and were conducted in nearly all intervention and control facilities. And then finally, turning to mechanisms of impact, there are two areas of concern to highlight here. First, safe care rests on the assumption that improving these structural quality measures will feed through into improvements in clinical quality. But we know from a lot of evidence from the literature that often these two are actually quite poorly correlated. And secondly, it rests on the assumption that healthcare providers will have sufficient incentives to want to make the improvements in quality of care. And the concerns that these may have been too weak. So finally, looking at recommendations for future programs, it seems that both these mechanisms may need strengthening through a greater focus on improving care processes as well as structural quality measures, and by looking for stronger financial or regulatory incentives for quality improvement, perhaps by linking safe care scores to facility empanelment in social health insurance or to regulatory penalties. We could also look to improve the efficiency of the intervention, perhaps by targeting fewer high volume facilities or those that seem more committed to making quality improvement, and also by exploring digital strategies to try and increase intervention intensity where network access permits. And finally, I think we'd like to highlight and applaud Farm Access for having done a really rigorous evaluation of this intervention. It is disappointing in some ways the results for clinical quality of care, but it's notable that these aren't out of line with other previous results on accreditation or other vaguely similar interventions that are taking place at the moment. So I think we all still have a great deal to learn here, and there's a need for considerable innovation and continued robust evaluation going forward. So thank you all very much.
Thank you so much, Professor Goodman. That was really wonderful. And again, I would echo your thing. This is a really remarkable endeavor to do this as an RCT, and really looking forward to digging more into some of the measures and some of the results. And then I'm absolutely delighted to present our final speaker, Sahana Shafiq, who leads the Urban Health Research Group at the Health Systems and Population Studies Division of ICDDRB in Bangladesh. She completed her bachelor's and master's in nutrition, MPH from the University of Queensland, and a PhD in nutritional epidemiology from the University of Toronto. She is interested in health policy and systems research and implementation research in the areas of urban health and nutrition, generating evidence and knowledge translation to achieve universal health coverage in Bangladesh. Delighted to now hear the presentation.
Hello everyone, greetings from Bangladesh. This is Sahana Shafiq from ICDDRB. Like many other low and middle income countries, Bangladesh is also going through a rapid urbanization, and there are huge inequalities in maternal, child health, nutrition, and in many other urban health indicators. From this graph, as you can see that although there are some reduction in stunting, underweight, and wasting compared to the city corporation non-slum areas, urban health slum areas have very high rates of these indicators. In the last couple of decades, there has been actually a lot of emphasis on ICTs for health in Bangladesh. But urban health is very complex in Bangladesh, and where while the Ministry of Health looks after the health of the rural areas, urban health is governed by local government, and it's also supported by NGOs and private sector. So the rural areas, Ministry of Health through the DG Health and DG Family Planning, they are using District Health Information System 2. There are routinely data are being collected on various indicators. However, this is not being seen in the urban areas. So there is no timely, accurate data that is actually for informed decision making in the urban setting to support the governance in urban areas. So how to strengthen urban health governance? To answer what services exist and where they're located, who provides them, what is the service coverage gaps and duplication, and whether these facilities are registered or licensed, and what are the affordability and quality of the services. So we need to actually find out a solution. So what was ICDDB's solution? It was a georeference ICT tool to strengthen urban health governance. It is called Urban Health Atlas. It is an interactive web-based visualization tool that shows the location and service details of healthcare facilities in major cities in Bangladesh. The aim and the objective of this particular study was to understand the process of institutionalizing Urban Health Atlas for strengthening urban health service planning, decision-making, and oversight at local and national levels. The objective of this study was to document stakeholder perception of and experience with the tool and how it could be made more user-friendly and relevant, and identify and test strategies to facilitate this institutionalization process and explore policy and programmatic entry points. So we conducted an implementation research in one city corporation and 2 municipalities, Joshua and Dinajpur. And the study was conducted among health managers, statisticians from Ministry of Health and local government, NGO managers, and academicians. 45 key informant interviews and in-depth interviews were collected, and we also actually documented the click stream and user log and costing data for this Urban Health Atlas tool and its institutionalization process. So there we had actually some capacity building workshop. Hands-on trainings were held. 6 trainings were done in 3 cities. There were 2 days orientation and 1 day refresher training for about 20 to 25 per batch. So what do we actually mean by institutionalization? By institutionalization of Urban Health Atlas, we mean the uptake, use, and update of this tool. Uptake means the motivation for engagement. Use means the application of the tool, and update is by the government keeping it relevant to the user need, finally, so that it can strengthen urban health governance. So what we see that there are some factors that influence urban health institutionalization process. For uptake, political commitment around this issue of ICT, how ICT was addressed. It was one of the act factor. Policy level support and experience with ICTs, presence of technology champion with influence, perceived utility of this tool versus cost of implementation, and availability of necessary infrastructure and training, as well as comfort of using this technology. For use, and having an user-friendly interface such as a Bangla version of it, and ongoing and continuous support and training around the tool, and whenever it was needed, it was also needed for this increase of the use and alignment of the task and job description, and a reliable ICT infrastructure and support for actually maintenance of this ICT infrastructure. And for the factors that influence update, it was having a formal mechanism for updating. So at the moment, there are weak capacity at the local level, and there are limited urban mandate at the national level. So, and as well as turnover of those in the key position making, it also actually has a lot of influence in the updating of this institutionalization of the Urban Health Atlas. So one of the idea we found, it was shared, one of the managers shared that, I'm quoting, we utilize this tool, Urban Health Atlas, in a 5-year planning of the health services. Previously, all the health facilities were concentrated in district hospital, and service gaps were found in the wards 3 and 4. Around that, and then around 11.5 and around 11.5 and 4. And we decided to redistribute the facilities, and this tool helped us a lot. One of the problems of Urban Health Atlas is that there is a systems for routing data collection usage. There is no system for the routing data collection for using it. And if it was linked with the DHIS2, then it would have been used more frequently. So the suggestion was actually for having an instruction from an upper level, so that would to make it actually institutionalized in the government system. So one of the key informants said, there are multiple state and non-state actors in urban areas who can be benefited from this tool. In addition, the line director of hospital can use this for monitoring the private sector facilities from district to national level. If all actors agree to use it, urban of governance can be strengthened. So while the uptake of UHA, Urban Health Atlas, is promising, many challenges remain around its use and absence of commitments to maintain and update the data to support the complex urban health governance. To determine whether the institutionalization of ICTs for healthcare health are timely, realistic, and relevant, we need a clear understanding of context, actors, and system readiness for change. Baseline capacity and interest of using evidence for decision making, and jobs and functions in which ICTs are usually usefully applied, and finally define stakeholder commitments and systems to keep ICTs up to date. We would like to thank IDRC for supporting this study, and also our other donors who supported the development of Urban Health Atlas. Thank you very much.
Wonderful, thank you so much. And again, I think really interesting insights into how we can think differently about how to improve our quality. I'm delighted that we've had a number of really exciting questions, and I have a bunch as well, should we need some extra time. And if I could ask if your bandwidth allows for the presenters to put back on their videos and then unmute as you answer calls, as you answer specific questions. So I will start here. So the first question is here we go, for Munir. And the question is, did you have any challenges in using HCAP's tool to your context? Did you feel it was easily transferable? And that's the first question, but it's also a question I had in terms of not just linguistic translation, but also cultural translation in the scores and in the areas. So Munir, could you answer that question?
Sure, thank you very much. Interesting question. Yeah, I think we didn't actually find any challenge in terms of linguistic or cultural translation. The items were quite similar, except for a few demographic questions. We talk about ethnicity, so we have different ones, and we had to use language around an item around language rather than ethnicity, because it's just we don't have many different ethnicities in our part of the world. And we also had to add two measures around trainee physician communication, because we felt they are important part of the medical team, and they are the ones who are looking after the families when the consultant is around just for a few minutes in the ward round, and they are being taken care of by the trainee physicians. And we included 6 items and 2 measures for measuring resident or the trainee physician communication with the families. The rest of the things, if they come from the ER or they come from outpatient department, is there anything around child's comfort? I think pretty much it's the same thing. And I think clinical care probably, it's also, I think most of the physicians that we have been trained in the US, in the hospital that I work in. So probably they have brought a system that was similar to what their training was. We didn't feel any challenges such in terms of translation of the items.
Great, thank you so much. Next, there's a question for Jessica. And the question is, did you look at whether specific management indicators impacted more on quality than others, rather than only using the overall index?
Hi, thanks. Hopefully you can hear me.
Yes.
Yes, fantastic. It's an interesting question. We didn't look at that. And it might be something that we would explore in the future. I think one of the things is our kind of set of management practices is very much designed to try and capture the concept of management, rather than thinking that perhaps each of those specific measures would necessarily have a direct impact on quality. So, for example, we ask about, do you have performance indicators? Do you produce a report of the indicators? Do you have targets for the indicators? Which obviously you wouldn't necessarily expect that to impact on whether asthma patients get given their inhaler, but more points towards the sort of overall quality of management, which I think is one of the reasons we've avoided looking at those specific indicators rather than the whole thing.
Mm-hmm. Great. Before I get to the next question, it's for Catherine. This is both for Catherine and Jessica, so I'm taking chair prerogative. I know that measuring management is often quite challenging. We've done some work in Uganda and Ghana, and trying to sort of collapse it down to something that doesn't take a huge amount of expertise, like the World Management Survey, is quite challenging. So I'd love to know a little bit more about the management measurement tools you used, and whether they're ones which might be applicable or usable in other settings and in other countries. So either Catherine or Jessica.
Okay, I think I'll take that. So it was quite a challenge. We started working from, I think it was actually a generic quality management tool, not necessarily for health facilities. Tim really led the design of those tools, which I can't remember why we started, but actually it really changed a lot through piloting, and there was a huge challenge trying to make them appropriate to the setting that we were using, because we were using loads of technical terms that just didn't make sense in health facilities, because these were small health facilities that didn't think of themselves as having the kind of big management structures that we think about. Things like mission health facilities would say that they weren't a business, so why would they have a profit and loss account? So you had to work quite hard to come up with an appropriate set of indicators, and I think we ended up reducing down the number of indicators. So we've got 13, whereas we started with a longer list, but some of them just had to be crossed off. I think they have captured the quality of management quite well, and certainly they're kind of available in the, and we've got a paper submitted that's under review, and hopefully people will want to share them, because especially for small health facilities, they seem to do the job nicely. I don't know if Catherine wants to add anything.
Yeah, no, thanks, Jess. I think I completely agree with what you said. We were recreating our tool as we move around the country, doing piloting for other things, and we understood more about how a lot of these quite small facilities actually operate and what is sensible for management. But one other thing we found is that we had to have a two-stage process. So we would ask the questions of the manager, and then we would actually ask them to take us to see some kind of evidence of what they were talking about. So if we asked if they kept financial records, records of some kind, or if they did staff appraisal, we'd then go around together and we'd sort of open up their books, and often we'd kind of correct the score at that point because it helped us all understand what we were trying to get at. So it involves a lot of communication on the ground, I think.
Great, thank you so much. I'm going to ask one more and then go on to a question for Sahana. So for Catherine, does the evaluation suggest any ideas about what explained the lack of impact, although not the focus of the evaluation recognized?
So sure, so thanks for that question. That's the big issue, I guess. We did have a process evaluation that I didn't present on today, but that we conducted alongside, which involved both sort of looking at quantitative indicators of implementation, but also qualitative interviews with facility staff and the implementing partners. I suppose for me, it probably comes down to two things. The first is intensity, and the second is incentives. I think if you even look at the design of the intervention to start with, even had it been implemented to the intensity they had intended, it's not that intense. They're hoping to have a quarterly visit from a mentor and maybe 2 formal training sessions. So that's not that intense an intervention anyway, when you think of a facility and all the things that are going on for them and trying to manage patients and everything else they're doing. And in fact, the intensity was quite a bit lower. So that's maybe one question, is like, can you do something more intense? And is that even feasible financially, is a good question. How would you do something more intense? And would you need to say, use more digital technologies, for instance, to enable you to do something more intense? But I think the other key issue is incentives. Facilities love safe care. If you ask any of them, would you recommend safe care? They're like, yes, it's fantastic. And when you talk to them, they say, well, it's great. We don't have to pay anything for it. And the subtext, which they don't say, is there are no penalties really if they don't comply. So there aren't any regulatory penalties. They're not going to get closed down. And there also aren't direct financial benefits. So it's not like it's linked to empanelment in social health insurance, for instance. So you're really relying on either their motivation to want to do it, which a subset of facilities have, but not all facilities, or you're relying on the idea that the patients are going to be able to perceive the improvement. That's sort of how their theory of change works. The patients will say, oh, it's got so much better, many more patients will go, they'll do much better in business terms and so on. But I think that we know that there are major disjunctures between what patients perceive and the actual quality in the facility. So I don't think that incentive mechanism works that well. So I guess my view would be you need to sort of think more strongly about either motivational or incentive mechanisms.
Great, thank you so much. And I think, you know, there's sort of announcements as the World Health Organization is continuing to maintain and increase its focus on primary healthcare, has just come out with a new organizational framework. And I think thinking about measurement and therefore feasible measurement tools and interventions that can help strengthen related to quality, I think are clearly an area where there's going to be some exciting work and opportunities in the coming year. So here's a question for you, Sahana. What is the source of data in the UHA? Is it facility registration data? How complete is that? Or do you rely on other sources to get locations for all facilities? And what variables did the UHA include? So you get 4 questions for the price of 1. Sahana?
Okay, all right, thank you. Yes, can you hear me, Lisa?
Yes, great, thank you.
Lisa, can you hear me?
Yes.
Can you hear me, Lisa?
Yes.
Okay, all right, thank you. Sorry about that, the delay. Yes, the Urban Health Atlas, that was actually, it was a census of all health facilities that was done in 9 major cities by ICDDRB. So it was, we have done census of the cities and look at what services they provide, the cost of service, the opening hours, and whether they had some kind of specialized services or not. So all those services were listed. So you could actually, you could search for this specific facilities by some specific health problems or the type of facilities, whether it's government or whether it's private, or like what kind of primary, secondary, or tertiary level care they're providing. So this is actually and that was done and organized by ICDDRB. And the second part of the question, Lisa, if you could actually repeat that.
Sorry.
There is some delay.
When we started, we said the most frequent term everybody's using is, oh, you're still on mute. So apologies, I was on mute. So the second part was, yeah, what are the variables does the UHA include?
Yes, I think actually I have mentioned that already, and but there was a specific focus on maternal health, adolescent family planning, and some of those variables. But in general, it was basically an urban atlas it developed some maps of and that shows actually gaps and duplication of services, for example, and where the facilities are located. For example, with the if there is a government health sector, like the private healthcare providers are around and that government health sectors, and how actually these are like having some kind of duplication in some areas for services, whereas in other areas where the poor are located, there is a lack of services. So this gives you a kind of a visual understanding actually for decision making, if we have to reallocate the services and where people should go, and also the shortest route to the services. Where can you go and seek care in the shortest possible time? So this is some of the tools, or I would say that the aspects of the Urban Health Atlas that provides you those kind of information.
Great, thank you so much. I'm going to go back now to Catherine and Jessica, and then I have a question actually for Munira. So I'm going to combine two questions for you. And so the question was, what definition of management did you use? And would it be worth focusing more on management in terms of motivation as specific possible influence over quality? So that's both to Jessica or Catherine. I'll defer to you who answers.
I think that was Catherine gesturing for me to answer. I've just been looking through our paper actually to find the definition of management that we used, and quite embarrassingly, we never actually define exactly what we mean by management, but I think I would say it's the sort of quality of leadership and organisation of the health facility. In terms of management versus motivation, so actually I saw another question that Lucy asked about the kind of facility specific context, which I think she might be getting at things like whether it's a mission facility or for-profit facility or other kind of factors about the facility, which I suppose speaks to that. And we did find that management good management had a bigger association with good quality care in the for-profit facilities. And our sort of hypothesis around that was perhaps that in the mission, not-for-profit health facilities, there was more of a sort of intrinsic motivation to provide good care. And then perhaps it's in those for-profit health facilities where the quality of management matters more. So I think it's really hard for me to say which matters more. I think it is quite context dependent. I think the sort of the safe care study as a whole really goes to show that incentives, as in motivation, matter, but the management has an impact too.
Yeah, so let me just, thanks, Jess. And well, we must come up with a definition for management. Thank you, Lucy. It's a good idea. But I think one of the questions you had, as I understood it, was sort of getting at whether we should try and focus, if we see a relationship between management and clinical quality, should we try and focus interventions on management as a sort of theory of change to try and influence clinical quality? And I think that's a really open question. I guess safe care partly is about management. Some people see it as a management intervention, even though it sort of covers things holistically across the facility in clinical and non-clinical areas. So it certainly has a management component already. I guess our results show that if there is some degree of positive relationship there, you could hypothesize that an intervention to improve management could improve clinical quality, but we certainly can't say that from the data that Jess has presented today on management, because that's really just a cross-sectional association. So it may be that our management measure is correlated with something else, which is also correlated with clinical quality. So I think we don't know that yet. And I think even within our team, we sort of oscillate between thinking, the solution to this problem is to go kind of more organizational, more systems level, and in thinking, what is the solution actually to go the other way and go right down, focus more on process, clinical quality intervention, and really thinking about working clinically with physicians. And I think we don't really know the answer of which direction you should go in. I'd be interested to hear your thoughts on that.
Unfortunately, I don't think we can actually get verbal. It's one of the things, obviously, among many things, that it's challenging to do virtually, but I think really great response, and hopefully can connect later on that. Manira, I have a question for you. So I'm very interested that you looked at both leadership. So we've been talking about management, and often leadership becomes part of it, and also experiential quality. And again, I was similar to some of the questions that we've had for Jess and for Catherine. How did you measure the experience? What sort of tools did you use in the sense of, again, what was the most effective or less so with the HCAPS, which has, and if you were to recommend for somebody else, and particularly, how did you define and how did you measure leadership? So are there tools, again, which other people can adapt and adopt, as I always say?
Yeah, thank you very much for asking this question. I think that has been the limitation of our study. We have not been able to measure leadership or leadership attributes as we started. It was a quality improvement project within an existing setting, and we did bring in someone to work on the leadership skills, and we kind of measured the effectiveness of the intervention in terms of patient experience outcomes or the employee engagement output, but we couldn't really measure what's changed in the leadership style. We also had a social media communication strategy, and the way the leaders communicated over time could be something that we could look into, how their communication has changed with the employees on that page, which is still actually running and people is still being used. But during the intervention period, there was a change in the way people were communicating with each other. Maybe that's one way that we can look at of leadership experience, or the way the leadership style is improving in terms of connecting with employees. Since it was a healthcare setting, we were looking at compassionate leadership. So leadership that can connect with you, that can empathize with you, that is ready to listen to you. Then those were some of the skills that could be seen in the communication that was going on. But yeah, that has been a limitation. In terms of patient experience, it's a quantitative survey, and there has been criticism on it. It doesn't measure the actual elements of empathy and compassion. And it may be right to some extent, but we used it very differently. We didn't use it post-admission. It was during their stay when the patients were in the hospital. So in the acute ward, the average length of stay is 4 days. We divided the age caps into two. We used it 2 different time points. So one was after half of the stay was over, like after 48 hours of admission. We used the experience indicators, which were around communication about mistakes, and with the parents informed about the mistakes and the concerns that were made about the lab test and things like that. And the items around discharge were asked when they were about to discharge or that day. And also the main outcome, which was, will they be willing to recommend this hospital to someone else, to their family or friends? That was something we measured again when they were about to leave on the last day of their discharge. So, and we had someone who actually asked this in person. So it was not a paper form that they were filling. There was an associate who was in the hospital, who was independent of the intervention team completely, and someone who had time to talk to them, build rapport with them, and then she would do the experience items. And then she would also do the discharge items. So I think that also broke down a lot of barrier that could have come from just filling a form. And we also included one open-ended item that was asked about. So if you were to recommend to the hospital administration to improve 3 things for you to improve your experience, what would your 3 priorities be? I think that to me was one of the most significant item that was very much revealing on what patient priorities are in terms of their experience. And the first priority came up to be we need someone to respond to us when we need a doctor or we need a nurse. There's nobody available, nobody to talk to. That was the first thing that they talked to us about their priority. And second one was communication. The information needs were not met. What do these lab tests mean? We don't know. We're not given a copy of the lab test in the hospital. We're likely to discuss with someone else, with another physician. Yes, I think complementing with some of these kind of tweaks that we made or having a qualitative item that can add a huge deal to the way patient experience can be measured.
Great, thank you so much. I think that's really, really helpful and brings out this idea about how important the patient experience is, but also sometimes how challenging it can be to do that. So we're going to go back a little bit to some of the management questions. So this is a question from Lucy. I was wondering whether management as management of people is different from management of, for example, information in terms of impacts on quality. Again, I agree, Lucy, that you can't interact, but I think that's a very interesting thing is that there is this idea as we talk about motivation and incentivization about how you do human resource management versus management of some of the other key inputs into there. And I'm wondering again, back to Catherine and Jessica, but also for other people, as you're thinking about this idea of using management as a lever, and so Manira, you can also comment because yours was really focusing on this leadership. Should we and how do we think differently about management of human resources of the people who are working there, and then management of some of the key aspects and inputs that are needed for them to actually be able to provide care? And opening that up for anybody. Or I can call on people.
I'll kick off. I mean, I guess we could see whether we can look at our data empirically to look at different elements of management. So we could see if that's possible and get back to you. I suppose what's running through my head is that there can be both positive and negative forms of intensity of management of people, particularly in the private sector. So I suppose what I'm getting at is kind of perverse incentives in terms of quality of care as well as positive incentives. So strengthening the control of management over individual clinicians or control may be the wrong word, but strengthening engagement may have a positive effect, may support them to deliver better quality of care, or for instance, may involve greater focus on whether they're bringing in enough money for the facility and how that could be maximized and how they could be incentivized to do that more. So I think whenever we're working in facilities where we're aware of the kind of sort of background environment of profit incentives, we're thinking about that. So I think that would be an interesting complexity to explore. I'll stop there.
And I think you're bringing up a very interesting thing. If we look at the diversity of settings in which these studies were done, typically people say, oh, it's a health system, but is it public? Is it private? Is it tertiary? Which is, I think, one of the questions for Manira, which is, you did this in a tertiary hospital, and therefore, how would you have to think about doing something similar to that at a lower level facility? So perhaps even talking a little bit about these two different types of management, but also the different sectors and health systems. So Manira, any thoughts on that about how your work might be applicable in lower level facilities?
Yeah, very interesting question. We actually did pilot it in the community health worker program. So we have a lady health worker program, if people are aware of it. It's a large network of community health workers, probably one of the largest CHTV programs in the world. And we did it in 2 districts. In 10 different sub-districts of 2 districts in Sindh, which is about 30,000 families. And we had 300 lady health workers. So I did envision to pilot it in a large scale in that facility, but all we could do was we could train the lady health supervisors, and I tried to strengthen the supervision system and to train these supervisors for compassionate leadership. Because for a worker, your system is your supervisor. Your make or break at your workplace is the person you interact with every day, and that's how that's representative of your system of your healthcare. So my understanding was, or my vision was, if you could build in compassion within existing supervision system, it becomes mentorship. And mentorship is something that is hugely missing, I feel, in the health sector, health program. And we had a 5-way training. We introduced it was actually early child development intervention, which focuses on early childhood experiences between mother and the child. But for someone to interact or someone to help those mothers provide those experiences to these kids, these mothers need to have the same experience, because it's at a community level these experiences are missing. An experience of empathy, of sensitivity, of responsivity. And if the lady health workers needs to provide those experiences to the mother, she needs to have that experience herself from her own system. So we introduce that vision of compassionate care, but in a way that your employee or your lady health worker also is benefiting from that experience or compassion. And we operationalized compassion into different 9 skills, and we trained the lady health supervisor, and we had like 6-month pilot where we visit the lady health supervisor, and we would observe her as she would interact with her lady health worker. And after that happened, we would give her, like, we had a session. So what did you observe, and did you show gratitude, and where was the autism piece, and where was the like courage piece. And I think, and you know what was the most difficult part was actually helping the lady health supervisors appreciate their own lady health workers in front of these mothers. So these are some very small gestures which can mean a lot to these workers. So we did try to do that, but I think I also realized it requires much more investment in terms of the top leadership and willingness of, because if that comes through their own system and it becomes as part of their own system of being mentors or being compassionate, I think it's much more easier to be to guide them along those lines or to build that. But it was something that they really appreciated. Some of them said it's the first time they have started seeing their fellow workers who they always thought were not important, but they are a valuable piece of the system. And there have been conversations about integrating that compassionate supervision piece within the existing supervision system of the lady health worker program, because there have been revisions of the lady health worker curriculum. There's nothing around the lady health supervisor curriculum. So there have been conversations around that as well. And I think bringing to the first question that you had was what are some of the ways that we can look at in terms of management leadership and managing humans versus managing non-humanistic things. I think to me, being a psychologist, I think the most underused resource is human resource. If you could tap into what humans are possible, I mean, we have examples in history where world is changed by just one individual. You need to bring that vision. You just need to bring people together. People are not hungry for money. People are hungry for value. They're hungry for recognition. And that vision, if someone really gets it, a leader gets it, I think these humans can do wonders. But I think my learning was...
Sorry, I just need you to wrap up because we're almost out of time. Sorry.
Just one last bit. I think we need to realize that leaders are humans and they are as vulnerable as anyone else. And their vulnerabilities also need to be taken care of in these initiatives.
Great. Thank you so much. And I think this has really been wonderful, really thinking very creatively about how do we think about management and leadership? What are the outcomes as we try to use that as a lever? This idea of management of, as you say, human and non-humanistic resources that are there. How do we make management more compassionate? I think some of the mentorship is really important, and we sort of highlight some of the mentorship work that Health Systems Global has been doing in terms of developing in research, but perhaps these are other opportunities as well. And so I want to bring this to a close. I want to thank all of our attendees for coming and listening in. I want to thank very much our presenters for really wonderful work. I'm hoping that this will result in ongoing discussions and ongoing collaborations and sharing of the tools that are being developed to address this. So thank you all very much.